the case, but now that I see it clearly, I'm going to win this debate. But I'll argue in the abstract. So first, I want to thank the organizing committee. I'm desperately looking for this bus that goes around here to put IV fluids in you after a hard night in Vegas. And thanks, I think Larry Kumite had something to do with a late start, well, which is very helpful for us here. So thank you very much for that. Well, okay, so this is really exciting. We have a couple options for approach, and there's a lot of anterior, lateral type of approaches. And I know Will Smith's going to speak later about how he can do this in special ways. But for most of us, we are picking the level of approach, and that will dictate to some degree what we're going to do. But the advantage of going posteriorly is you can get anything, and anybody in the room can do it. So that, by definition, means it's applicable. I like the caveat, independent of cost and surgeon skill, but the reality is those are huge hard decks for us, right? But I'm going to take a different tack on this. I'm going to give two arguments on this. The first one's an ethical one, okay? And this relates to the issue of how we choose the surgery for the patient, okay? So number one, spine surgeons, and we all know this innately, should always be most concerned about downside risk. We know that because we pay the most malpractice insurance of any specialty in medicine, right? So if you look at anterior surgery, there's no question, and Luis is here, it's highly effective, and it's changed a lot of what we do as spine surgeons. So there's no question there's real advantages to anterior or lateral approaches, right? And there's a lot of approaches, O-lift, D-lift, ATP, whatever you want to call it, all these types of approaches, but look at the kind of complications. So you go in the back, okay, there's back pain, there's CSF leakage, and if you really suck, you can hurt a nerve, right? But you can be really good and get these types of complications with a lateral or anterior approach, right? It seems to be a stochastic phenomenon that you can be the best surgeon in the world and someone can die on your table from a vascular injury. So what about all these types of complications? I mean, it's been great for me because it allows me to publish the new kinds of complications with these new approaches, but these are real ethical issues we need to confront as spine surgeons that we didn't face before. And people are going crazy. Look at this. This is not a lateral approach, it's an anterior approach, but this is absolutely off the charts, and I apologize if anybody in the room did this surgery, but this is crazy. I mean, this is ridiculous. Who would do this to someone, right? So the second thing about this is that the degree to which an MIS surgery is MIS is cumulative to the whole surgical enterprise. So, I mean, Bob is a good-looking guy, and, they always, I don't want to comment on intelligence, but he's a very good-looking guy. And this is what they're saying, okay? I'm not going to go after Will, because at least he's an ideologue. He's saying, we're just going to do lateral. But 1 + 1 is not 1. 1 + 1 is 2. So if you do 2 surgeries on someone, that's 2 operations. The surgery is defined by the additive aspects, the additive risks. So you don't say, I did a small MIS portion and then did a big whack, like Juan was talking about, and that's a small surgery. That's a bigger surgery than a big open operation, right? So then the question is, okay, can the posterior MIS accomplish goals? We know the open surgery can, right? So can it do that? And so, this slide's already been shown twice today, and I like it because it brings up a lot of issues for us. So the question is, can you get, like this case, MIS T-lifts, and get this type of correction and this type of correction? And yes, you can. You can get what you need by going from the back only, right? You can do a mini open PSO like this, and you can get substantial corrections without having to do anything fancy, right? And that allows us to take a less invasive approach. And we talked about this just now, right? You can do direct and indirect decompression. You don't have to pick. You do the direct and indirect without having to change your approach or the position of the patient or anything about the consent. You just do it. If you need to do it, you do it. You put in the cages, you lift up, you get whatever you need. So the second argument is economic, okay? And this is an important one because I think that it's kind of like the elephant in the room because we're all, a bunch of millionaires, right? Everybody in this room, right? And so it's really easy to say, well, we just whack people and we get what we want, right? But the cost of the procedure is directly related to its complexity. Implants, biologics, operating time, length of hospitalization, complications, and the cost of managing them, right? So every complication you get, what does that do? It triples the amount of cost for that operation. So try to keep it simple. That's the whole virtue of being quote-unquote MIS. So what is this really about? Well, if we were to, and I apologize, I didn't have the case, but I assumed it'd be something like an L2 to S1 or something like that. So these are some various options, right? Posterior open, MIS, 4-level, standalone, lateral, right? Front back MIS, right? And all these things are really relevant. But look at the RVU differences when you do these kinds of surgeries. This is really what's going on. Now, I might lose this argument based on this, right? Because we all want more RVUs, right? But the reality is these are human beings we're operating on, right? So I love these guys, but in conclusion, I have to say there are a lot of ways to fix this patient, right? The simplest way is best, and the way that's best in your hands is best, right? But I always say the simplest is best, because even if I'm a great surgeon, I'm still going to fuck it up occasionally, right? So simplest is best. Each individual approach adds risk. It adds stochastic risk. I don't care how good you are. Choose the method with the lowest complication rate. And we don't want to get into this habit of making our patients into like rotisserie chicken, right? This really gets to me. Like my partners are always like front, back, front, back, front, back, front, back, back, front, back, front, back. And then the residents are like, wow, it's so cool. I'm like, that's a human being you're operating on who's under anesthesia for 14 hours, right? So try to avoid that temptation. You don't want your patients to end up like that. Thank you very much.